Hi, friends. I'm Dr. Emma Mary, a gynecologist today. We're diving into a topic that affects so many people but is often misunderstood PCOS. I'm going to lay out all the facts for you, right here, right now. Hi, friends, and welcome back. In today's video, I'm breaking down PCOS, Polycystic Ovarian Syndrome. So, what is PCOS? Simply put, it's a hormone disorder that prevents you from ovulating. Now, let me be clear. PCOS gets misunderstood all the time. And one of my biggest pet peeves as a fertility doctor is hearing people who don't have the same level of training as I do, or who just don't fully understand the physiology behind PCOS, claim that this condition is really just a problem of having low progesterone. No, okay? That's like saying the issue is only a secondary symptom. Yes, low progesterone is a symptom, but the true root cause is a hormone disturbance that leads to you not ovulating. And if you don't ovulate, your body simply cannot make progesterone. So, let's walk through what PCOS actually is. First of all, I absolutely hate the name Polycystic Ovarian Syndrome. Whoever named it, terrible choice. I really dislike this name. But here's what it actually refers to. The cysts in PCOS are tiny, fluid-filled follicles. On an ultrasound, any fluid-filled structure is technically called a cyst. However, these cysts aren't actually problematic. Follicles are completely normal. They're part of how your eggs grow. In PCOS, you just happen to have more than the usual number of them. Now, officially, to diagnose PCOS, you need 2 out of 3 specific criteria. Let me break those down for you. Number 1, irregular periods. If your menstrual cycles are consistently irregular, that meets part of the diagnostic criteria. Number 2, signs of high androgens. Androgens are hormones like testosterone or DHEAS, which are produced by either the ovaries or the adrenal glands. These can cause acne or excess hair growth. So, whether you experience those symptoms, acne or unwanted hair growth, or you get a blood test showing elevated levels of these hormones, that also counts toward the diagnosis. Number 3, a specific ultrasound appearance where the ovaries look polycystic, meaning there are many small follicles or a high antral follicle count. That's the official Rotterdam criteria. That is how a doctor should diagnose PCOS. That said, if you already have 2 out of the 3, for example, irregular cycles plus acne, your doctor might not even order an ultrasound because you've already met the diagnostic threshold. So, depending on what symptoms you're presenting with and what your health goals are, different doctors may take different approaches. As a fertility doctor, I perform ultrasounds all the time. It's one of my top tools for evaluating a patient. So, you'll see me use ultrasound frequently. But it's not always necessary for everyone. Even though those are the diagnostic criteria, they don't exactly explain why the problem happens. They just describe the symptoms. So, let me draw you a picture. And fair warning, I'm not the world's best artist. So, imagine you have your pituitary gland in your brain and your ovary. That's the normal setup. Normally, your brain sends out a hormone called FSH, follicle stimulating hormone. FSH is actually a well-named hormone because it does exactly what it sounds like. It stimulates your follicles to grow. I like to use this analogy. Inside your ovary, there's a vault. And inside that vault are all the eggs you will ever have. When you're born, that vault is full. When you go through menopause, that vault is empty. Every single month, a group of eggs comes out of that vault. You can actually see that group on an ultrasound. You can't see inside the vault itself. That's like a secret. But you can see the group of eggs that emerges. Each one of those eggs grows inside a follicle. So if you look at an ultrasound, you'd see many follicles in the ovary. And those are the cysts, fluid-filled structures, each containing 1 egg. Now, when your brain sends out FSH, it talks to the ovary. If everything is working normally, the ovary responds, and 1 follicle will grow larger, and that egg will mature. That's the one you ovulate. One of my favorite things about the ovary is that it's a hormone-producing factory. When the ovary does its job correctly, it makes estrogen. That's its main hormone of the moment. But when things stop working correctly, the ovary switches gears and starts making another hormone, testosterone. So what really happens in PCOS? I like to think of it as being born with a very full vault. A full vault means your ovary has a lot of eggs. And here's a cool fact about the body. The more eggs you have in that vault, the more eggs are released every month. The fewer eggs in the vault, the fewer are released each month. So when you have a lot of eggs, more follicles come out at once. That's why the diagnostic criteria show lots of follicles. But here's the issue. Your brain sends out a normal amount of FSH, but that FSH gets diluted across all those small follicles. As a result, none of them gets chosen to fully respond. They just sit there, basically doing nothing. Well, actually, they're not doing nothing. They're each making a tiny, tiny amount of estrogen, and estrogen is what talks back to the brain. Normally, estrogen is only made in higher doses when the body is ovulating. That high dose tells the brain, cool, don't send out any more FSH, we're good, we're making an egg. But when all those tiny follicles each make a teeny bit of estrogen, that small amount is still enough to signal the brain, we're fine. So the brain doesn't send out more FSH, and you get stuck in this loop. A little bit of FSH, a little bit of estradiol, and no ovulation. Now remember, the ovary is a hormone-producing factory. So if it's stuck in this cycle, guess what starts happening? FSH has a sister hormone called LH. LH is also released from the brain, but it works on the ovary in a different way. LH starts telling the ovary, make testosterone, make testosterone. If the ovary isn't ovulating, it can't make estrogen. The factory can't do its normal job, so it shifts to making testosterone instead. And that testosterone is what leads to acne and excess hair growth. So that's a big part of the problem. Another thing that confuses people about PCOS is the whole weight gain issue. I like to describe two main forms of PCOS. First, there's the thin phenotype, which has nothing to do with weight gain. That's really just a PCOS hormone issue in the ovary. It's an ovarian endocrine disorder. The ovary doesn't produce the hormones it should because it gets trapped in this pathway of not doing anything, not enough FSH. And then it starts making testosterone. Other things that happen with PCOS, high testosterone levels can also cause insulin resistance and lead to metabolic changes. That's why we often see PCOS associated with diabetes, high blood pressure, high cholesterol, and all kinds of other issues. To make things more complicated, fat cells also make estrogen. So if you are overweight and have a lot of fat cells, those fat cells produce estrogen. That extra estrogen talks to the brain and tells it not to send out enough FSH. So PCOS can also appear in women who are overweight. But here's the confusing part. Women often hear, oh, just lose 10% of your body weight and you'll start ovulating again. That is true if you have extra estrogen being made by fat cells, because if you lose weight, that extra estrogen will drop. However, if you have thin PCOS and it's purely a hormone dysfunction, do not go lose weight. It won't make any difference because weight is not the root cause of your problem. If you've had irregular cycles your whole life when you were thin and now you're overweight, weight loss may not be a major player for you. If you're thin, you don't need to lose weight. That won't help your problem. If you're overweight, then trying to lose some weight will always be recommended as part of the treatment. A quick note. We're going to do a follow-up video answering your questions about PCOS, so please ask them in the comments. We'll also talk about different treatment options, but let me explain why birth control pills are so popular for PCOS. One reason is that they provide constant levels of estrogen and progesterone. One of the biggest risks with PCOS that you often hear about is endometrial cancer. When we talk about long-term risks, endometrial cancer is a concern because all those small follicles making a little bit of estrogen don't just talk to the brain, they also talk to the uterus. And when estrogen talks to the uterus, it tells the uterine lining to fill up and grow, preparing for an implantation that's never going to happen because you don't ovulate. So the lining just keeps growing and getting fluffier, and you're not bleeding it off like you should because you never get that rise and fall of progesterone that comes with ovulation. This condition can be called hyperplasia, and it can turn into cancer. So low progesterone by itself is just a sign that you're not ovulating. But that situation can actually lead to endometrial cancer. That's why doctors sometimes talk about protecting the endometrium by giving you some progesterone or inducing a withdrawal bleed or doing something so those cells don't turn into cancer. Because we don't want you to experience the worst possible outcome from this condition. Again, low progesterone is not the problem. The problem is everything I just described. Low progesterone is a symptom. If you don't ovulate, you don't make progesterone. Progesterone is the only hormone made solely because of ovulation. It will not exist in your body without ovulation. If you are trying to get pregnant and your periods are irregular, you need to see a doctor. End of story. If your periods are irregular and you have symptoms of PCOS, you might want to see a doctor even before you start trying to conceive. Sometimes lifestyle changes like diet, supplements, or losing weight, if that applies to you, can help this process. But sometimes you're already really healthy and you have refractory PCOS, meaning you'll need medications to help you ovulate. And that's okay. That's what your friendly fertility doctors are here for. We are here to help you get to that next step. What I don't want is all the stigma that we always see around PCOS. I want women to understand that low progesterone is not the real problem. Low progesterone is a symptom. The real problem is a hormone dysfunction. And when other endocrine glands in your body don't function well, nobody puts a big stigma on them. So let's break the stigma with PCOS. Let's educate ourselves and others. Thank you guys so much for watching. As always, I would love it if you subscribe to the channel so I can bring more fertility-related education and information to you. Thank you guys so much.